This is Cate Swannell for the MJA, and our special guests today are Dr Lee Gruner, President of the Royal Australasian College of Medical Administrators, and Dr Karen Owen, who is Chief Executive of RACMA. Welcome, and thank you for your time today.
Okay.
Why do people become medical administrators rather than practicing doctors, if you see what I mean?
Well,
Dr.
I
Gruner?
think what we have to say is they start off as practicing doctors,
Yep.
and some of them actually continue to practice on patients.
Mm-hmm.
But the reason why most of them give for being in medical administration is they want to make a difference, and they want to make a difference to larger populations than they can as a patient, and it gives them an opportunity to influence healthcare systems.
Right. And policy as well, is it about?
Yes. Anything to do with the healthcare system, and so people will go into different areas. So some will work in hospitals, some will work in government, some will work in pharmaceutical firms. So you do get a very good opportunity to influence policy at higher levels. Yes.
And what sort of range of careers are we talking about? Are we talking about hospital administration? Are there other things?
There are many, many careers. Our fellows come from a broad range of areas. So some of them, as I said, will continue in clinical practice and might do half-time management, and so they'll be specialists in all fields. Some of them will work in hospitals. Some of them will work at senior levels in government and, up to commissioner level.
Yep.
Many of them will do that. Some of them will work in big pharmaceutical firms. A lot of them work in the military. So we have a large component in the military. And what other careers, Karen, do we have? We do have some others, I hope.
Well, if you look at our statistics,
Yeah.
they're generally held at around 60% of our fellows
Yeah.
in hospital settings.
Right.
So there's another 40%
Out there.
in non-hospital settings, and as Lee says, they're in departments of immigration, departments of health.
Yeah.
They're advising ministers, insurance agencies,
Yep.
running huge pathology businesses,
Okay.
detention centres.
I was going to ask. Yep.
Strategic organisations, TGA, pharmaceuticals, e-health, and management consulting.
So you can have a wide range of interests.
Yes.
Involved. That's terrific.
It's a career with lots of opportunities.
Yeah.
I think, because of that.
Is there a shortage of medical administrators and people coming through from the younger students and junior doctors?
We argue that there is.
Yeah.
And the basis for our case is the numbers of our fellows who reach the age at which they can take their defined benefits super schemes,
Right.
and then commence another career through locum work.
Okay.
And they are placed in 3 to 6 month positions, generally in regional, rural areas, but not only there. So they embark upon a new lifestyle of providing medical administrative services into hospitals in non-metropolitan areas where it's very difficult to generally get, for the same reasons as any clinician.
Yeah.
Find it very difficult to attract them to go and work there. So we have numbers of our senior fellows who go into those sorts of roles, and we have a number of our fellows who actually run these businesses providing locum placements. So they build up very strong relationships between those hospitals and, I suppose, a panel of our people. We also know from our own workforce census, we've done 2 of these in recent years, and we've asked our members what their plans are for retirement and career change, and we've done some analysis using hospital data and size of hospital, beds and structures around management in those hospitals, and we've come up with an estimate of about 4,500 positions where we believe there could be a trained fellow of our college and where there currently is not.
Yeah.
So if we accept that and the premises behind that statistical analysis, yes, there's a shortage.
So how do you convince students and junior doctors that this is a career path that's going to be good for them?
Well, we have a number of ways, I guess, of doing that. Used to be, and we were talking earlier, it used to be a lot easier. The professional medical manager was much more visible because there was fewer layers in between them and other people. And for instance, when I was starting, you reported directly to the doctor who is medical administration. Now we have what we have in between called an HMO, Hospital Medical Officer Unit, that does a lot of that. And often when you talk to younger doctors, that's all they see.
Right.
And so part of the ways of promoting is for the person in the senior position to actually go out and be visible amongst the junior doctors so that they see that there's a job there and they see that that's interesting. Part of what's been done, and for instance Western Australia is a pretty good case where they've been actually bringing doctors into quality projects so that they can see what the broad range of the hospital provides and they can see that there's actually a different career out there that they can take. We have at the college what we call a young doctors group where we reach out to doctors who perhaps might be interested in a management career, and that group is going, and there are some enthusiastic people, and some of the people that have come to us now as our trainees have come through that young doctors group. And we really try and get out there and do a bit of promotion of whatever is available to do that. Part of the shortage has been the baby boomer it's been happening. As we know, there are now a lot more medical graduates, and so there's a lot more opportunity to get people into our specialty. And so we now really can go out there and start talking a lot more to junior doctors because there are a lot more positions available. I guess the other thing is too that we've had a problem over a period of 10 years where there probably haven't been enough positions available to replace ourselves.
Right.
With the STP from the federal government, we have actually managed to garner quite a lot of positions that we've been able to fill, and so we're starting to address that. And then you've talked about the young doctors, but many of our doctors that we get are not the young doctors. They're the doctors who are staying in their 40s or 50s. I've been managing a unit or a department. I actually want to do a bit more of the management, a bit less of the clinical work. And so we have a large number of fellows who are dual qualified and who move into either full-time or very close to full-time medical management.
And for very experienced doctors, we have
that means very experienced in management.
Right,
so pre-existing experience.
Yep.
So we have accelerated pathways, and we go through a quite rigorous interview process for these applicants. And the aim of that is to form an assessment of their current competency in order that their training program towards fellowship be reduced in length and more focused on filling the gaps in competency.
Yes.
So we have two of those pathways. So they're based on recognition of prior learning and granting of credit for certain academic training we undertake. So that's been a very successful pathway for us. We really formalised it in 2010. And we've had 7 cohorts come through that accelerated pathway. So we're probably looking at close to 200 doctors. So these are people who are very, very senior clinician managers or people who are already in directors of medical services roles, mostly working in hospitals, and at the cusp of that career decision about whether to leave behind the clinical or formalise their management qualifications because they've already left the clinical. And since the National Registration Scheme came in, it has, I suspect, been a decision point for a number of very senior specialists, clinical specialists, as to whether to continue to maintain multiple specialties and all the CPD requirements and so on that go with that. And I think as we move further down the line with the revalidation conversation that the medical board has established, we will see even more impetus to decision making around it. And hopefully, for our college, those who are already working in medical management roles in that scope of practice will formalise through coming to this college as fellows.
And those accelerated people, the ones who've done it really quickly, have been ready to actually sit their fellowship, and they have to do the final fellowship exam within a year.
Right.
Yeah.
I'm looking around the walls in here and noticing that I think there's 2 women. 2?
Yes, 2 women.
That's right. Lee's going to be the
yes.
third, but
Yes.
Lee's space is
Not yet filled.
No.
What is the gender balance like in medical administration?
There are more men than women.
Yeah.
I should be able to quote you that, but I can't. I think there's about a third women to
about 25, 60.
And is that something that's grown in recent times, or is it?
It's always been a career that's had about that number of women, actually.
Is that a work-life balance thing?
Yes, I think, part of it has been that.
Yeah.
And part of it, women are good at relationships and communication and that sort of thing, and that goes with management really well, I think.
Yeah.
I think that's been part of it too.
It's been an interesting couple of years here, politically, for health and medicine. And we've got a new federal minister now in Susan Lee. What do you, as a college, see as the big issues that need tackling in the next year to 5 years, say? Yes. How long is the list?
Look, I guess as medical managers, we look at it very much, from a helicopter view and say, what are the systems? And there are things that are problems in systems that we don't think that they'll ever be fixed. I mean, one of the problems is the multiplicity of funding, and particularly federal state. But, we're realistic enough to know that, it's unlikely that that's going to change. I don't think our constitution is going to change.
Yeah.
So, but that's one of the issues, is that sort of funding issue and the priorities issue. What sort of priorities do we have?
Yeah.
And a lot of us have been interested in that we don't do enough for prevention in Australia. So we do a lot for the acute and the glamour things, not enough on prevention and how much we could actually save if we worked down the preventative, non-glamorous end rather than the high end. So there's some of the things that some of us are interested in. We're very interested in the issues around professional standards, and so most of the other colleges are interested in professional standards for their own college, but because we work across all the specialties, we're actually interested in professional standards for everybody, for all people who are working in medicine. So we're interested in the revalidation debate and what that's going to mean, and we're particularly keen that it should be something that should be useful but not low cost and, not too complex, and deliver what's needed to be delivered rather than something that's going the way of the UK, which is incredibly expensive and you're not quite sure what outcomes you're going to get. So we're interested in all of that professional standards area. I think most of us are interested in having healthcare delivery that's really patient-focused and is cost-effective. We're very interested in cost-effective care.
Are you happy as a college with the level of consultation that's been undertaken by the government in the last, since they became the government, basically?
It hasn't been a wonderful level of consultation, I don't think. But I think, again, it's a two-way street.
Yes.
And we can't just rely on the government to come to us, talking about the whole medical fraternity. We have to actually go to them. And some of the stuff that we've been doing in the college, and which other colleges do as well, might I say. But we make sure that we build relationships at government levels so that we can get some of our views across and get some changes made in that way. So I do think it needs to be two-way. And for people to just wait for the government to come to you, well, nothing's going to happen. We really have to go out there to them.
Can you tell us a bit about the Young Doctors training pathway into fellowship or into administration?
Well, the youngest doctors would come in at PGY4, their equivalent.
Yep.
And they're predominantly public hospital-based.
Yep.
In fact, they probably all are public hospital-based because that's where the funding is provided.
Mm-hmm.
The exception has been in the last 3 or 4 years. The college has been successful in gaining funding through the Commonwealth Government Specialist Training Program.
Right.
And private hospital settings are part of the objective to expand the settings in which young doctors are training.
Mm.
So we have about 18 training posts funded by the Commonwealth as distinct from the jurisdictional governments.
Yep.
And that has enabled the young doctor, the PGY4,
Yep.
to enter into our training programs. So that's been a very successful program. And our junior doctor program, which is not our training program,
Yep.
these are young doctors who may still be at university or in that PGY 1, 2 and 3 time. We've got about 80 on our books. And we have a soft approach. We communicate with our e-newsletters and we invite them and give them concessions to our conferences, and our jurisdictional committees hopefully will meet with them. And but it still comes down to them finding a funded training post
Yes.
to enter. So they learn about us through the junior doctor program, and we're most fortunate where we have a fellow already in those hospitals, and they become mentors for these very young doctors, and they I'm going to do.
So they have to do 3 years clinical experience before they're accepted
Right.
as a trainee
Yeah.
in our college. We call them candidates. It gets, but they have to do that 3 years, so they can't come in earlier than PGY4. And so we have a group that comes in at PGY4, and some will come in, maybe a couple of years later,
Yeah.
having decided I don't like that specialty or that specialty, this is the one that interests me. And then it's a 3-year training program generally.